Today, we're going to be talking about factor 11 inhibition, ensuring safety and efficacy. I'm joined today by Johnston, who's a stroke neurologist in San Francisco, and by Rasha Al-Lamee, who is a interventional cardiologist at Imperial College in London, England. So we have a terrific faculty for you today, and you can scan this QR code to get CME information. The learning objectives for today's webinars are to first explain how factor 11A inhibitors may attenuate thrombosis without disrupting hemostasis. We're then going to review the limitations of current therapies for secondary prevention of non-cardioembolic ischemic stroke and outline the limitation of antiplatelet therapy for the prevention of recurrent ischemic events in people with acute coronary syndrome. Now, everybody's coming in muted. You can use the raise hand option to speak. You can use the Q&A function for questions, and that's the preferred way as you listening to us. Put your questions into the Q&A. You can contact the France Foundation if you're having any technical issues, and we're recording this meeting. So I'm going to start by doing a quick knowledge check and ask a few questions, which you can answer by scanning the QR code and getting right into the question. I'm going to talk briefly about the promise of factor 11A inhibition and how it might uncouple thrombosis and hemostasis. Then we're going to hear about the unmet needs in secondary stroke prevention. And then we'll hear about the unmet needs in acute coronary syndrome. We'll then have a chance for question and answers, and I look forward to addressing any questions that you have. So the first of the knowledge questions, again, scan the QR code to answer the question. What is the primary mechanism by which factor 11A contributes to thrombus growth? Is it by activating platelets, by initiating the extrinsic pathway of coagulation, by amplifying thrombin generation, or by inhibiting fibrinolysis? And I'll give you a few moments to address that. The next question, again, scan the QR code. Which of the following applies to current therapies for secondary prevention in non-cardioembolic ischemic stroke? Do the current therapies have high efficacy in preventing stroke recurrence in all patient subgroups? Do they pose an acceptable risk of bleeding? Is there a high residual risk of recurrent stroke despite their appropriate use? And is there consistent benefits across different ethnic and age groups? Which of these is correct? And the next question relates to the COMPASS trial. Which of the following was a key finding from the COMPASS study? Rivaroxaban plus aspirin significantly increased major bleeding. Rivaroxaban plus aspirin had minimal impact on major vascular events in patients with stable coronary artery disease. Rivaroxaban alone significantly increased mortality rates, or rivaroxaban alone significantly decreased major bleeding. Please find the most appropriate answer. Great. So let me start by discussing the promise of factor 11A inhibition. So here I show you on the left-hand side the pathway to hemostasis, and on the right side, the pathway to thrombosis. So both of these processes involve the formation of a clot, but the site of clot formation is different. Hemostasis is the process by which holes or damage to the vessel wall is plugged with a clot to prevent blood loss. This is a mostly extravascular event that is triggered by an outside-inside injury to the vessel. The cut in the vessel exposes the blood to the very large concentrations of tissue factor that surround the blood vessel in form of the hemostatic envelope. This large amount of tissue factor triggers explosive thrombin generation that results in clot formation without, to the large part, any need for involvement of factor 11. Contrast this to thrombosis. Thrombosis is intravascular clot formation, and what we're concerned about is that the clot inside a vessel will grow to the point where it obstructs the lumen of the vessel and blocks blood flow. Now, intravascular clot formation is triggered by a small amount of tissue factor that might be exposed to the blood when an atherosclerotic plaque is disrupted. This small amount of tissue factor induces the formation of a small amount of thrombin, and in order for this thrombin to induce that clot to grow, it has to feed back, activate factor 11, and generate more 10A and more thrombin. So what we can see here is that the current anticoagulants, the direct oral anticoagulants that inhibit factor 10A or thrombin, address clotting enzymes in the common pathway that is common to both the hemostatic pathway and thrombosis, either 10A or thrombin. And for this reason, these agents can't distinguish between the bleeding problem and the thrombosis problem. And inevitably, if we increase the dose, we get more bleeding. So bleeding remains the major complication of these treatments. Let's contrast that to factor 11. Factor 11 inhibitors will inhibit factor 11 or factor 11A, and because factor 11 is important for thrombosis, but mostly redundant from hemostasis, 11A inhibitors or 11 inhibitors have the potential to achieve that holy grail of anticoagulation of attenuating thrombosis with little or no disruption of hemostasis. Now we have different types of factor 11 inhibitors. We have antisense oligonucleotides that reduce the hepatic synthesis of factor 11, and this is a first generation and a second generation antisense oligonucleotide, and fesomersen is the second generation agent. These agents are given subcutaneously, and they have a long half-life. We have monoclonal antibodies that come in different forms. We have examples here of different monoclonal antibodies that either block factor 11A activity, block factor 11 activation, or do both. These antibodies can be given intravenously for rapid onset of action or subcutaneously for a slower onset but longer onset of action. And they are not cleared through the kidneys, so you can dial out any drug-drug interactions. And finally, we have small molecule inhibitors, which, like the current DOACs, bind reversibly to the active site of factor 11A and block its activity. These are given orally And the two that are most advanced in development are asundexian and milvexian. Asundexian is given once a day. Milvexian is given twice a day. Now, development of new anticoagulants usually starts in patients undergoing orthopedic surgery because such patients are at risk for deep vein thrombosis unless thromboprophylaxis is given. And this deep vein thrombosis, which is often asymptomatic, can be efficiently detected with routine venography done about 10 to 12 days after the surgery. So for factor 11 inhibitors, the antisense oligonucleotide 2 antibodies, the sosumab and abelacimab, and one small molecule inhibitor, milvexian, were compared with enoxaparin or Lofinox in this setting. And this meta-analysis shows that compared with the enoxaparin, the factor 11 inhibitors were associated with about a 40% reduction in the risk of postoperative venous thromboembolism and about a 60% reduction in clinically relevant bleeding, the composite of major and clinically relevant non-major bleeding. So these data show great promise that the factor 11 inhibitors can indeed reduce thrombosis without increasing the risk of bleeding. So we now have phase 3 trials that are ongoing, 3 of them with abelacimab. The LILAC trial is comparing the abelacimab once monthly injections with placebo in patients with atrial fibrillation who are considered not to be candidates for current oral anticoagulants. And we have ASTER and Magnolia, which are comparing abelacimab with apixaban in ASTER, with dalteparin and Magnolia in patients with cancer-associated thrombosis. And the difference in these two studies is that the ASTER study is geared to patients at lower risk for bleeding, and the Magnolia for those at higher risk, such as those with gastrointestinal or gastroesophageal cancers. For asundexian, the Oceanic AF trial comparing asundexian with apixaban was stopped because of reduced efficacy of asundexian compared with apixaban. The Oceanic Stroke study comparing asundexian with placebo on top of single or dual antiplatelet therapy is ongoing. And for milvexian, 3 studies, XIa AF, comparing milvexian with apixaban in patients with AF, and XIa ACS and XIa Stroke, comparing milvexian with placebo on top of single or dual antiplatelet therapy in patients with acute coronary syndrome or in those with non-cardioembolic stroke. To set the stage of why these studies are ongoing and what the unmet needs are in non-cardioembolic stroke and ACS, you're going to hear the subsequent presentations. So in summary, my key takeaways: targeting factor 11 has the potential to reduce the burden of thromboembolic cardiovascular disease while preserving hemostasis, and we're eagerly awaiting the results of these phase 3 trials to establish their benefit-risk profiles. So I'm going to stop sharing and pass the stage to Clay.
So I'm going to take us a little deeper on the stroke prevention, and in particular secondary stroke prevention. So I want to set the stage because I realize that's probably a topic that this group speaks about or hears about less. And so there are a number of conditions that antithrombotics may be effective for that have huge burden on the worldwide population. Ischemic stroke affects 77 million people worldwide. It causes 63 million years lost to death or disability. So huge cause for major disability. number one or number two, depending on whether you count depression or not, and then contributes 3.3 million deaths a year. So it's the second most common cause of death. These numbers are actually increasing, not decreasing worldwide, not just with population, but as the population ages. Particularly in developing countries. Atrial fibrillation also, of course, has a major impact. Similar number of people affected, but less of an impact on disability or death. But obviously an important target for stroke prevention. And then ischemic heart disease, of course, is the number one worldwide cause of death, although produces less disability. So stroke is important worldwide. It's still important too in the developed world as well, although we've been fortunate enough to see a decline in its importance as a cause of death. It's now the number 5 in the U.S. and in Europe. Cause of deaths used to be number 2. So of stroke, hemorrhagic stroke accounts for just 13% of total strokes. I'm not going to talk as much about that, although that's obviously a bleeding complication that one would like to avoid. But ischemic stroke is really the dominant type of strokes. And then underneath that, there are a number of different etiologies of stroke. Cardiogenic embolism, atrial fibrillation being the major cause of that, accounting for 20 to 30% of all ischemic strokes, with a recurrence rate of about 1 to 2% per year. And then a series of ones that need to be targeted where we don't really know the role for anticoagulation. That includes large artery atherosclerosis, so that would be carotid disease or intrinsic endovascular arterial disease, and that's a big portion, 15 to 25% of strokes, with a really high risk of recurrence, 5 to 8% over a 9-month period, a little bit longer over a year, a little bit greater over a year. And then there's lacunar disease or small artery disease. This is intrinsic small vessel disease, hypertension, diabetes being major contributors to that. And that's 20-25% of the population of ischemic strokes, and a recurrence risk of 2 to 3% afterwards. And then cryptogenic. And unfortunately, there are a number of these. We're just not sure whether this was an intrinsic small vessel, whether it was truly embolic and we just didn't have a good cardiac source, or whether it was a large artery source that we just couldn't identify the ruptured plaque or the area of stenosis. That accounts for 30 to 40% and has a recurrence rate of about 4 to 5% a year. There's also a bunch of weird causes that we're not going to talk about today, account for roughly 5% of all strokes. Those are things like dissections or arteritis, the unusual etiologies. So this risk of recurrence. So, I should say on the last slide, about 20-25% of ischemic strokes are recurrent strokes. So, yes, we need to work on primary prevention as well. And in atrial fibrillation, that is primary prevention, use of anticoagulation. There is a lot we can do in preventing a recurrent stroke. And there's some urgency in doing that as well, because the risk of recurrence is quite high, whether it's in this case, it's a minor stroke or TIA. I'm showing you data here for, but that is also true for more major strokes. There's a substantial risk early on. So just within the first day, you have a 5, 6, 7% risk. And then, over a month, that can be 11.5 to 17% at 3 months. We brought these, and they're similar for minor stroke. We brought these down to some extent. You can see this is 2004 with current therapy, but there's still, half of this, which is really high and really important to find treatments for. That risk isn't just in the acute period. If you follow people for a while after TIA or minor stroke, you can see that the risk of stroke continues. So this is cerebrovascular events that include stroke and TIA. For stroke alone, it's this dotted line curve. That's the most important one. And after a year, you're still at 1% a year. So, not insignificant major risks for stroke during follow-up in something that, requires specific therapies. So where are we today in terms of specific therapies? Well, again, for the atrial fibrillation, not really talking about that group. Anticoagulation is recommended. For that group that we are talking about, the non-cardiomyopathic ischemic strokes, the recommendation for secondary prevention is on really dual antiplatelet therapy for the majority of that group. So that would be with clopidogrel and aspirin, where we've got 2 randomized trials that support the use of those, and they're highly effective in that setting, or ticagrelor and aspirin, particularly if there's a risk that they don't normally metabolize clopidogrel. So this is actually quite short, though, in duration. So this is recommended just for the first 21 to 90 days. And then after this, I'm not showing you those recommendations. The recommendation is single antiplatelet therapy. So after stroke, dual antiplatelet therapy for the majority initially, transitioning to single antiplatelet therapy afterwards. That could be aspirin or clopidogrel. Those are really the two that are most commonly used in that setting. No role for anticoagulation defined in guidelines beyond cardioembolic stroke for secondary stroke prevention today. Not that we haven't had trials, we have, but the trials have always shown a reduction in ischemic event that is accompanied by an increase in the risk of hemorrhage, and therefore those long-term anticoagulation as secondary stroke prevention, non-cardioembolic, is not recommended in the guidelines today. Even antiplatelet therapy is not well used or liked after stroke, and this is just showing you the trends. Yes, we have a lot more dual antiplatelet therapy in people who really should be on it. But even there, where the majority of people are just getting single antiplatelet therapy with aspirin, in the long term for sure, and even in the short term, a significant portion of people are receiving that. And even with that, the event rates remain quite high with dual antiplatelet therapy and with aspirin in modern management. The COMPASS trial. So this was one of the questions that you were asked about. So this has brought some renewed interest in long-term anticoagulation, and this is just looking at the very broad population with atherosclerosis that is included in the COMPASS trial, but then following that group for ischemic stroke or stroke of where you couldn't identify whether it was ischemic or hemorrhagic. And it showed, again, real risks of these events over time of stroke. So, basically about 0.5% a year. Again, this is not a secondary stroke prevention population necessarily. There were some that did have prior strokes, but most were cardiovascular events. And you can see that there was an apparent reduction with rivaroxaban plus aspirin compared to either rivaroxaban alone or aspirin alone, particularly in that early separation, in fewer folks towards the right, so it wouldn't overinterpret that reconvergence of rivaroxaban plus aspirin versus rivaroxaban alone. So some apparent role in long-term prevention of ischemic stroke in a broad group of folks with atherosclerosis. But there was, so you look at the difference there, the absolute difference in ischemic events is about 1%. See that, here versus here. But the difference in major bleeding is also 1%. So that combination versus aspirin alone is increasing the risk of major bleeding. And once again, we're seeing, okay, yes, it may be effective, but it comes at the cost of major bleeding. So based on the exciting early work to show that targeting factor 11A could provide a way to disconnect a benefit in reducing ischemic events from risk of hemorrhage, there have been a couple of trials done, phase 2 trials, specifically in secondary stroke prevention. And they're the Pacific Stroke trial of asundexian and the axiomatic SSP trial of milvexian. Both of these were dose ranging, so meant to be helpful in finding the right dose for a phase 3 trial. And they both included, roughly a couple thousand folks with minor ischemic stroke and high-risk TIA. Why that population? We just have a lot more data in that population. We know the recurrence risk is quite high in that population for major, more severe strokes. There's, competing issues like death and complications. The risk of hemorrhage in general is greater in that population, and it's harder to detect new ischemic events in that population. So that's the reason both of these have targeted this more minor ischemic stroke population. Both relatively short duration the trials, and both had used a primary outcome that was ischemic stroke or MRI infarction. So the notion here is that infarction to the brain is bad, whether symptoms are recognized or not. And so maybe we know that there's at least one silent infarct for every obvious stroke. And so, this could be a way to increase sensitivity in the trial, increase event rate to be helpful in a phase 2B trial. But what those trials found was both encouraging, but also not as encouraging as we might have hoped. Neither of them found a dose response for the primary outcome, that composite of infarct or ischemic stroke, and it was really the silent infarct piece that messed that up. And it may be that we're calling something an infarct that wasn't an infarct on those MRI scans, but for whatever reason that did not show a signal that the primary outcome event that was selected for the trial. But encouragingly, there was no elevated risk of major hemorrhage, so very safe across the range of doses. And then when we pulled out the symptomatic ischemic strokes and look at those separately, there were trends towards protection with milvexian versus placebo. This is a little confusing. This meta-analysis includes a couple of other trials, Pacific AF and Pacific AMI. So those are in looking at stroke events in those trials, but those trials are really not designed as secondary stroke prevention trials. And so if you just look at the blue boxes, it shows you, I think, what makes the most sense in terms of summarizing data from prior trials and understanding whether we may have a drug that could work for in a phase 3 trial. So that is the basis. That, as well as the total knee replacement data that Jeff showed us, that's the basis for moving forward with those phase 3 trials that Jeff mentioned, that that are now ongoing and we're excited to see results for in secondary stroke prevention. So my key takeaways are the global burden of ischemic stroke and TIA is tremendous. For ischemic stroke, I showed you just how profound it is as a cause of death and disability worldwide. TIA, there are probably an equal number of TIAs as strokes, and as you saw, very high risk of stroke afterwards. So super important to address that need for secondary stroke prevention. The risk of recurrent ischemic stroke is quite high, particularly in the acute period, but it remains elevated for the long term, and even with ideal therapies that we have today. So there's clearly an unmet need for long-term therapies that can reduce that risk, that secondary stroke risk, with hopefully do that in a way that that doesn't cause hemorrhage. And factor 11A inhibition may provide that route forward. So phase 2 data intriguing, requires further exploration, and we're excited to see the phase 3 trial results come out as they will. So with that, I'm going to turn it over to Rasha.
Thank you, Clay. And now Rasha is going to talk about the unmet needs in acute coronary syndrome.
Thank you very much for the opportunity to speak today. Hopefully you can see my slides and hear me well. So I'm an interventional cardiologist at Imperial College in London, and I'm going to talk to you about where I see the unmet needs in acute coronary syndrome. So I think what's most interesting as an interventional cardiologist is that for most of us, patients come to the lab with their acute coronary syndrome. Many of those patients will have revascularization, and often we tell them that there's not much more to do. We tell them that with the right medication, they will do very well. But actually, we very often underappreciate the unidentified and ongoing risk in these patients. And in fact, when you look at the meta-analysis data, what you'll find is somewhere between 2 and 10% of patients have a residual risk of ischemic events. And what's most important to see is that while we know that in patients who have their first ACS event, around a third of them will have a major adverse cardiac event within 1 year, but actually nearly half of them will have a recurrent event within 3 years. And importantly, those recurrent events have very high mortality rates. You can see that with the first ST elevation MI, patients have a cumulative mortality rate that is high, but with recurrent ST elevation MI, it nearly doubles. And that's really important to remember. So for our patients who come back repeatedly, they have very high mortality rates, but in general, even after adequate revascularization, our patients with the lab, with cath lab intervention, will have residual events. Now, what's interesting to see is that some of this isn't really reflected in our guidelines. The current guidelines for treating acute coronary syndrome specifies antiplatelet therapy, and they talk about where antiplatelet therapy sits. The SC guidelines would tell us that dual antiplatelet therapy is recommended for the first 12 months after an acute coronary syndrome, and beyond those 12 months, a single antiplatelet therapy strategy is recommended. Indeed, there are now quite a lot of different studies and different criteria for potentially shortening the period of dual antiplatelet therapy and for reducing the potency of the antiplatelet therapy that we give. However, with all of those conversations comes a very high risk of ischemic events. And that's potentially because there is a residual risk that comes from something that we have underappreciated, which is a persistent increase in thrombin generation that goes on in our patients after their ACS. Now, interesting in this stable space, and Kay has already spoken to this, there have been studies around the addition of low-dose rivaroxaban with aspirin, and that's been shown to reduce ischemic events. But when you speak to people about the application of this data in clinical practice, that you'll find that most of them say they don't do it. And the reason they don't do it is because there is a knowledge of increased bleeding events with that addition of rivaroxaban. And it's that bleeding risk that for most physicians in their heads would say to them that the bleeding risk outweighs the reduction in ischemic events, and therefore they don't put their patients on this additional therapy. Now, what we do know is after acute coronary syndrome, the antiplatelet therapy alone leaves thrombin generation elevated. And in fact, you can see that thrombin elevation persists, and it can persist for many years after their acute coronary syndrome event. So it's not just a situation that you see immediately following the ACS event. It's something that persists over time. So the question is, what does that mean for these patients? Well, actually, this high thrombin generation is associated with a high risk of adverse events and also mortality. And what we see is that with elevated thrombin, we can see an elevated risk of recurrent events and more than a 3-fold risk of cardiovascular death. So this is really important to patients, and what you can see from our coagulation cascade here is that the antiplatelet therapy does not deal with this persistent thrombin generation. Now, in terms of the current oral anticoagulant agents, what we know is that they can reduce thrombin generation, but unfortunately they pose this bleeding risk, and we've already seen that from the data. And in fact, that bleeding risk is increased, of course, when an oral anticoagulant is added to antiplatelet therapy. And from single antiplatelet therapy to dual antiplatelet therapy, that risk increases further. And these bleeding events are not inconsequential for our patients. They obviously also pose major risk. What we saw from that COMPASS data again is a reduction in vascular events, but that reduction in vascular events was traded off by an increase in bleeding events. Now, how about after acute coronary syndrome? Well, here we have data from ATLAS, and the ATLAS data had some promise of an additional benefit in terms of event reduction with rivaroxaban versus placebo in acute coronary syndrome patients. And what's interesting to see is the benefit of thrombin inhibition is in addition to antiplatelet therapy in acute coronary syndrome patients. And you can see here a reduction in cardiovascular death, MI or stroke, but also in the isolated events of cardiovascular death and all-cause mortality. However, what we need to remember is that these agents are associated with increased bleeding risk. And as I said, bleeding risk is really important to patients too, and is in fact associated with increased all-cause mortality and 30-day MACE. And the more your patients may bleed, the more risk you'll see in those patients. So the low, moderate, high bleeding risk patients at the higher bleeding risk rates will see even higher MACE event rates. So it is really important to balance these two phenomena for our patients and think about how we can best reduce ischemic events without increasing bleeding events. So there is now the promise of some new agents, and we have an ongoing phase 3 trial testing cardiovascular outcomes for milvexian in acute coronary syndrome. Importantly, the patients are acute coronary syndrome patients who've had revascularization, who are on background dual antiplatelet therapy with aspirin and an oral P2Y12 inhibitor with the full range of those inhibitors available. The patients are randomized to have either milvexian orally twice a day or placebo. And this is a large international multi-center trial of 16,000 patients. So currently we're in the recruitment phase worldwide, and of course we expect to have data from this trial somewhere in the next few years, knowing that the primary endpoint is major adverse cardiac events. Now, it's powered for a 20% risk reduction in the milvexian arm. And importantly, in order to try and recruit patients who might get the most benefit from additional reduction in ischemic events, the trial was enriched, and the enrollment criteria encompassed patients who had to have at least 2 risk factors that may increase their risk of ischemic events. Risk factors such as their age, diabetes, a history of a prior MI, multivessel coronary artery disease, history of previous CABG, or previous known peripheral arterial disease. And importantly, there are a number of high-risk angiographic features, encompassing things like long stent length, thrombotic target lesions, things that we know are associated with increased ischemic events. Here's the study overview. Basically, patients within 7 days of their presentation with acute coronary syndrome will be recruited into the trial. And importantly, the randomization is also based on the dual antiplatelet therapy that patients might have and the plans for de-escalation, so that we can see whether there's any additional benefit on milvexian based on the dual antiplatelet therapy strategy. So what are the key takeaways that we've hopefully learned today? Well, hopefully we've learned that patients with acute coronary syndrome have a significantly high risk of recurrent cardiovascular events and than those who have not had acute coronary syndrome. And I think what's also important to remember is that the antiplatelet therapies that we have are not sufficient because thrombin generation remains elevated. And in fact, that bypasses the effects of the therapies that we have at the moment. It's also important to remember is that the promise of oral anticoagulant agents was limited by an increase in bleeding. And now we have data that's ongoing in various clinical trials, and we're waiting for that data for the factor 11 inhibitors such as milvexian, and we'll see what they might offer for our patients in future. So it's been a total pleasure to be here today with my co-presenters, with Jeff and Clay. And I'd like to just summarize some of what we've learned in this seminar today and then hand over for questions. So I think what we've learned is that targeting factor 11 and factor 11A has really a potential to reduce the burden of thromboembolic cardiovascular disease while preserving hemostasis. What we've also learned is that there's very high rates of recurrent ischemic strokes in our patients. And in those patients with ACS, they have a significantly higher risk of recurrent cardiovascular events than those without ACS. We've learned that factor 11, factor 11A inhibition can prevent benefits in reducing ischemic risk, hopefully without increasing the burden of bleeding. Now, we have phase 2 data that are intriguing and they need further exploration, but importantly, the phase 3 trials that really could have an impact on clinical practice are underway. And those ongoing clinical trials are very much eagerly awaited, and we'll wait and see what they show us, and I'll stop there.
Thank you so much, Rasha. Well, we're going to move now into the Q&A phase. We have some questions that were posed online, and I'll start and try and answer those quickly, and then we'll have a chance to, maybe I can pose a few questions to you people and get some answers to things that puzzle me. So there are 2 questions related to the use of factor 11 inhibitors for the treatment of venous thromboembolism, not prevention, like we saw in the orthopedic surgery, but treatment. And then the answer is yes. Abelacimab, the factor 11 inhibitory antibody, is being compared with apixaban or with dalteparin in patients with cancer-associated VTE. So we do have trials that are looking at factor 11 inhibition in patients with VTE. And I think, one of the interesting things about those trials is these patients already have thrombosis. So the idea that you can use a factor 11 inhibitor to treat existing thrombosis is interesting. Someone asked, are there antidotes for the 11A inhibitors? And no, there are no specific antidotes. We know from the XIa trial, a phase 2 trial comparing abelacimab with rivaroxaban for stroke prevention and atrial fibrillation, that patients underwent interventions, including surgery, without any bleeding, even though they had factor 11 inhibition on board. And plus, I think it's important to point out that the 2 trials we heard about today, the Librexia stroke and the asundexian stroke trial, so for the trials for stroke and the trial for ACS, are using a lower dose of milvexian than we're using for AF. So the risk of bleeding is going to be lower than it might be in the AF indication. But what we can do if someone bleeds is we can use tranexamic acid, and we can also bypass the factor 11 inhibition with low doses of activated factor 7. Somebody asks about the cost of these therapies. Too early to tell. What are the practical implications of patients on 11A inhibitors after surgery? Well, again, I told you that in these orthopedic studies, there were no particular problems, and so far in the AF studies, and we haven't seen a lot of serious bleeding events. I have a question for you, Rasha, and I have a question for you, Clay. That Rasha, you showed us the high residual risk despite antiplatelet therapy, and you showed us the the thing with the thrombin generation that persists. How do you envision pathophysiologically? What is driving that high residual risk? Is it rupture of atherothrombotic plaques in coronary arteries that weren't dealt with in the first intervention that you do? And what about, if you do an intervention, do you revascularize everything you can find, or do you just do the target lesion?
Yeah, so that's a really interesting question. So I think it'll be very interesting to see as we look at some of this trial data that comes out, what the impact is of complete versus incomplete revascularization. I suspect that that's not really what the story's about. I think it's probably about persistent atherosclerotic burden. And these are patients that we know will continue to have vulnerability in the plaque that they have. And I'm not sure that the revascularization or the stent does anything to reduce that risk. It's actually just about their overall burden. Do you agree with that, Jeff?
I do. And I think that it's intriguing because, as you know, if you have a plaque rupture in an artery, that plaque rupture can lead to an acute coronary syndrome, but it also could lead to a small clot that gets incorporated back into that plaque and causes it to grow. So by doing this dual pathway inhibition, we might attenuate that process and actually slow the progression of atherosclerosis in our patients with ACS.
Yeah, no, I think that's quite right. And I think one of the things that we are very bad at telling our patients actually after their ACS event is obviously about their persistent risk, but also about their ongoing disease process and disease burden, right? And the more we can think about this as a progressive disease that is not fixed at the point of revascularization, of course, we reduce cardiovascular mortality in that moment, but we don't reduce it over a lifespan if we still have persistent risk. And I think that's where we're thinking about additional therapies.
Jeff, you could have asked the same question about stroke.
Yeah.
Well,
I was going to ask you that, Clay, and I was going to ask you, you showed us the different types of non-cardioembolic ischemic stroke. And do you see a place for factor 11 inhibition in all of those subtypes? Or do you see that might be better placed for some rather than others?
Yeah, I don't think we know, but I think we do know that the large artery atherosclerosis, it's the most like the coronary artery disease that we were just talking about. And so, and has a very high recurrence risk. And so likely to be quite effective there. The same mechanisms and pathophysiology that underlie CAD. So the conversation that you were just having is highly relevant to that group. And then the small artery or lacunar disease is a different pathophysiology. Yeah. So at least, we're not great at identifying it, but we're trying to, when we define it that way, we're trying to pull out a kind of non-atherosclerotic intrinsic small vessel disease. In pathophysiologically, pathology is actually a intermedial hyperplasia. So it's in the small vessels themselves, they're impacted particularly by hypertension, but by other factors as well. It ends up that group does respond to antiplatelet therapy. That group does respond to TPA, so thrombolysis. So there is thrombus there, at least at the end of that. And so there is a reason to think there might be an effect. The other problem is we have so much trouble identifying that as a group that having I think it's important to at least test these agents in an all-inclusive stroke group, just because I'll just tell you in the trial where that the site-to-site variance in what they call a lacunar is huge. And current imaging, even with MRIs, doesn't tell you for sure it's an intrinsic small vessel disease. Mm-hmm. And so I think there's going to be some bleed over in terms of etiology, regardless of what definition is used. And then finally, that last column, the embolic stroke of unknown source, ESUS, that's a total wastebasket, right? So that's going to include some embolic strokes from things that respond well to anticoagulants. Paroxysmal atrial fibrillation sometimes gets into that category. And so I think it will be a group that has potential to respond to factor 11. The trials of DOACs in that setting have not been